Hi, Dr. Garima here. Yesterday I had shot this video of the same question, dense and dente, and somehow I tried and tried, but it wasn't just getting uploaded on YouTube. I reached out to their chat center also. They said wait for 48 hours. I still tried, nothing. So I'm thinking of reshooting it and hoping that this video gets uploaded because I really want to follow the sequence and have each question's explanation in place. So let's go ahead and solve another question of Australian Dental Council exam. For all the new candidates, this is how the questions are in ADC exam: scenario based questions, one main question, five sub questions. And today's question is very important. You will definitely get at least 10 questions on pediatric dentistry, and one of them would be where you will have to initiate some kind of an emergency response or refer the child to the hospital and plan some referrals, and you should know when to do that. So let's see what this question is all about. A 9-year-old boy has pain. Keyword pain. Whenever there is a keyword pain, it means you're supposed to do something. You just cannot like give medicine and send the patient back. The patient is in pain and something has to be done about it. Swelling in the infraorbital region. So swelling makes it even more serious. Infraorbital region is this area, dangerous area of the face. The eyes barely open, like the eyes almost closed. Fever 39.8 degrees. So clearly systemic manifestations are there. Tooth 1-2 is extremely painful to percussion. Extremely painful. Again, keyword. No caries is detected though. So if there is no caries and still the tooth is very, very sensitive to percussion and there is pain, it has to be either a fracture or some anomaly within the tooth or some trauma that has happened. Last 2 days he did not eat anything, so that makes him even more fragile, and you cannot just start an antibiotics orally because he's not eaten anything. Today he just sipped water, he looks very weak. So basically, he's systemically very down, and you have to do something to first take care of his life, and the tooth comes next. Okay, the overall health of the patient has to be managed here in the scenario more than the tooth. So first you have to make sure that the swelling and the systemic conditions are managed, and then you will come on to the tooth. You will not just be focused on the tooth and disregard the systemic state. You understand? So what does look abnormal about this immature tooth? Okay, a very straightforward question, but a very tricky question. It says, what does look abnormal about this immature tooth? Now, whenever there's an immature tooth, there will be an open apex. So that is not the abnormality in this tooth. The abnormality is this portion. All of you all must have studied oral pathology and would have studied a term called as dens in dente, and that is what it is. Dens invaginatus. There is a term called as dens evaginatus, which is like an extra pearl on the top of the tooth of enamel. The dens invaginatus is a tooth-like structure within a tooth-like structure. It's a very complicated anatomy, and if such a tooth happens to have some problem, doing a pulp therapy for this tooth becomes very complicated because you have to reach the actual pulp of the tooth and the pulp within the tooth of the tooth. So best left to the root canal specialist to treat such cases. So normally such teeth do not give problem, but because they may have severe folds in the several folds within the tooth within a tooth, there can be pits and fissures which may look like pinpoint from the clinical examination, but they're actually running right to the pulp. And whenever there is microbial colonization and the pathogenic bacteria are there, then it can lead to a scenario just like this. It can just lead to pulpal necrosis. And one day, just you wake up with swelling, and then you just don't know what to do about it. So what is this condition? This is dense and dente. It is not a supernumerary tooth. It's not a vertical fracture. Pulp stones don't look like this. Open apex. Open apex is not abnormal. It's a very normal scenario in an immature tooth. Remember this. Do not mark open apex out here. What is the best treatment course? Keyword best. Hundreds and thousands of time I have explained that whenever a keyword like best comes, that means all the options given would be correct. You have to choose which is the best possible option, like that. So, LA and start RCT now. Firstly, when there is a huge swelling, LA is not gonna work, and the the child clearly is not systematically stable to have any medicine, and he's very weak. So first thing is to make him healthy. You starting the root canal is not gonna do that, especially when your LA is not gonna work and the tooth is severe pain on percussion. So it's going to be a very difficult scenario if you just choose to start a treatment at that time. In your clinic, if you get such a case, I know all of us mostly tend to give antibiotics come after 5 days, but when there are systemic manifestations like fever, you have to refer the child to a hospital setting. You cannot treat that child until the child is healthy, but somebody has to treat the child to make him healthy. And the child has to take antibiotics and he cannot take them orally. So the best thing is IV antibiotics, hospitalization. Later on, when the child becomes healthy, then you make a decision on what you should be doing with the tooth. That is the ideal option. But that option is not given here. Instead, we have the option of hospitalization, IV antibiotics, and extraction. So, out of all the four given options, this is the best option that I can choose. The rest of the three options is not helping the child in the overall maintenance of his healthiness. So, I'm not going to choose the rest of the three options. I hope this is clear and you understand. Many of the candidates here have marked like LA extraction and drainage. LA is not going to work. You doing extraction and drainage on the spot is not going to help the child with the systemic manifestation things. He's not eaten for past 2 days. So how will he take the antibiotic orally? There has to be something in the stomach. The food has to be there. So IV antibiotics is the best thing. And you as a dentist cannot give IV antibiotics. Plus the child is febrile. His fever needs to also be managed. You as a dentist will not be managing the fever. So he has to be referred to a hospital setting. I hope this is clear. His mother is concerned about if extraction will be done, what will replace the tooth. Now, in case she thinks, okay, the extraction, if I go to the hospital and they remove the tooth, then what is going to come there? Now, such a question, you have to remember the age of the child because a certain age, you can do some things and you cannot do some things. So, definitely at the age of 9, you cannot do some things. So, you have to see the options, what options are there. Resin bonded bridge, which is like a Maryland bridge. It is usually given on central and the canine when the lateral is missing. But here, do we have a permanent canine? No. The permanent canine will come somewhere around the age of 12 or 13. So, right now, we have a deciduous canine. You cannot give a cantilever bridge on the deciduous canine. Why? Firstly, less area, it's a small tooth. And secondly, when the canines come, the intercanine width increases. So you don't want to stop the jaw from growing because you have held the teeth together. You understand? So no cantilever bridges, no resin bonded bridges. Removable partial denture, good. Do nothing, the canine will erupt in its place. No, the canine can erupt in the place of the deciduous tooth. It may by itself come to the position of the laterals. It's a very rare scenario, but you cannot just keep waiting for it to do that, to translate itself in the space of the lateral. Refer to an orthodontist for consultation and immediate implant. Immediate implant is out of question, the child is 9. Now, if I am stuck, I'll be stuck between a removable partial denture and referral to an orthodontist for consultation. Removable partial denture is a good choice. But when you will be planning for removable partial denture, that means you have already decided to maintain that space so that in future the child will go for FPD or implant. But you cannot make that decision unless the patient is aware of all the options. And what is the next best option is to get an orthodontic consultation where the orthodontist might suggest to put on braces, do a phase 1 treatment, and try and close that gap. Okay, so let the orthodontist give the mother full scenario of how he can drag the canine in the place of the lateral so that no removable partial denture is necessary and there is no space. So in future there would be no need of any implant or FPD, which is a very valid choice because you can always shape up the canine and make it look like a lateral, thereby saving you a lot of cost for the FPD and the implant later on. So let the orthodontist give all these kind of options to the parent, and let then the parent decide whether they want to go for removable partial denture or they wish to proceed with the orthodontist. You by yourself will not jump to save the space without letting the parent and the child know that there are other options also available. You understand that? So option D is the right choice. His mother would like to save the tooth and doesn't prefer the extraction option. What will you tell her? See, you are giving this exam as a general dentist. As a general dentist, you are expected to have just a limited set of knowledge. And in your limited set of knowledge, you're not expected to treat a tooth which is having dents and dente. So that is left best to the endodontist. So when the mother says, I want to save the tooth, and you have seen that the pulp is necrosed, what choices do you have? Would you tell her that saving the tooth will take much time and repeated visits to put calcium hydroxide until apex closure? No. MT is available. You can finish epexification in one sessions nowadays. RCT has very poor prognosis and extraction to be a better option. Not necessarily. If the endodontist feels they can save the teeth, why not? Refer to the endodontist after initial management. Yes. What is your initial management? Getting the patient healthy and removing the swelling off. RCT is impossible. No. Endodontist exists for a reason. Microscope is existing for a reason. The only way I feel RCT is impossible is when there is furcation involvement, or the patient is like highly uncooperative, or there is some systemic problem where you cannot do an RCT. Otherwise, pretty much RCT is very possible. The worst of the worst cases I've seen endodontists trying to save the tooth and have saved it. So the best option here is refer to the endodontist after the initial management and let them take care of the tooth, because you as a general dentist are not expected to have that kind of expertise and qualification and skills. And the other lateral incisor has the same clinical appearance but no symptoms, with normal response to vitality and no tenderness to percussion. Basically, it's acting like any other healthy tooth. The radiograph shows that the invagination is confined to the crown of the tooth. What will you do? So the other side lateral. So this IOPA, I know you see a periapical lesion over that lateral, but in the exam there was not. I cannot get the exam pictures because they will not give that. They will not leak their question bank. So on Google, the best possible picture that I could find, I found, and I've put it up here. So imagine there is no periapical lesion and the tooth is healthy with the same anomaly of dense imaginators. Now, what will you do? So, you know what happened to the other lateral incisor. It went problematic. So, what will you do to this tooth? Pulpectomy and initiate root closure? No. If the tooth is healthy, why do you want to touch the pulp? Sealing of any deep fissures and regular follow-up? Yes. See, fissures and pets are the main issues. They act like microscopic tunnels through which the bacteria can travel. So sealing them is the best option to avoid further ingress of the bacteria to the pulp and leading to its damage. Come again for follow-up is not bad, but if I have the option of sealing up of any deep fissures, I'm going to go with that. Prophylactic pulpotomy, I'm not going to touch the pulp if the tooth is healthy. So I hope this is clear. Please read more on the anomalies of teeth. Please read more on gemination, fusion, evaginators, invaginators, etc. And focus more on the keywords and pedo questions. You will definitely get pedo questions. People make a lot of mistake in pedo questions. Pedo treatment is not exactly the same as the adult treatment. So focus on the age of the patient and the overall scenario. I hope this is clear. Hope this video was fine with you. You understood stuff, and I hope this video gets uploaded and I don't have to shoot it again. Bye bye.